Good evening.
We are live now.
Good evening, Sanju from Nagpur. Good evening, Sanjay
Good
Marathe.
evening. Ajay, good evening. Good evening.
Good evening, respected
Sir, please
dignitaries, senior faculty, dinner colleagues, and friends. Myself, Dr. Sachin Patil, Scientific Co-Chairperson, MAHAIP 2026, along with my co-moderator, Dr. Malvika Kulkarni ma'am. On behalf of Maharashtra IP, it gives me great pleasure to welcome you all for this academic session, that is Masterclass in Pediatrics, Episode 3. Today's session is special as we are having Mahaguru of Vaccinology, respected Dr. Kasi sir, with us as an expert. Today's theme is Masterclass on Vaccinations. We have four eminent speakers, experts in vaccinology, respected Dr. Sanjay Marathe sir, Dr. Sumitha Nayak ma'am, Dr. Chetan Trivedi sir, and Dr. Kulkarni sir, who will share their wisdom with us. Now I request MAHAIP President, respected Dr. Sanjeev Joshi sir, to address the gathering. Over to you, Joshi sir, please.
Namaskar. A very good evening to everyone. All my OBs of the Maharashtra IP, EBs, also Central IP EBs, and today all the masters, and especially the master of the master, respected Kasi sir. At the outset, I express my sincere thanks to respected Kasi sir for accepting our invite and also adjusting the date as well, because there was some issue. Last Thursday we couldn't make it, but he kindly consented for today. And of course, we have three masters. They are not less than any stars in the horizon of immunology and vaccinology. They are none other than my dear friend Dr. Sanjay Marathe, Dr. Sagar, and of course Dr. Sumita. So I welcome
Dr.
you all
Trivedi
on
sir is
behalf
also
of-
there, sir.
and
Dr.
Dr. Chetan Trivedi. चेतन को कैसे भूल जाओ भाई and Dr. Chetan. So I welcome you all on behalf of the Maharashtra IP on this virtual platform. You know, vaccine is one of the favorite topics amongst the attendees, and definitely we will have a very good audience. We have already surpassed number 100, more than 100, and I think I am very optimistic to reach the number of 200 once we start. So today, nothing to talk about all our masters. They are really masters in the field of vaccinology. I wish all the virtual attendees on this platform a great learning, and definitely by the end of this talk, you will be back full of important take homes, important messages, and important answers to your queries related to the vaccines. Thank you all. Signing off. Over to Sachin.
Thank you, sir, for your thoughtful words and continued leadership. We are grateful for your encouragement and guidance. Dr. Vinayak Patki, sir. Dr. Vinayak Patil, sir, is there? Sir, President-elect MAHAIP.
No, sir.
No, okay. Now I request our MAHAIP Secretary, Dr. Renu Madam, to address the online delegates. Over to you, ma'am.
Yeah, good evening, one and all. Thank you for the opportunity, Dr. Sachin, and welcome all the dignitaries and respected Srinivasan sir from USA and our own masters of the masters, Dr. Kasi sir, Dr. Marathe sir, Dr. Trivedi sir, our own Dr. Sagar, who is our vaccine man from Chhatrapati Sambhaji Nagar, as we call him like that, and my president, Dr. Sanjeev Joshi and Sachin, and also Dr. Sumita Naik, ma'am, was my co-EB, and so many of my co-EBs have joined. I am seeing Dr. M.S. Vishwanathan, sir. Sir, welcome to this platform. Dr. Priya Shivali, Dr. Ramakrishna Paramahansa, sir, and Dr. Bela Verma, ma'am, who is our scientific convener, and she was also my co-EB. So I'm so much delightful that they have joined for our this masterclass, mainly because of the stalwarts who are there over here, and I won't take much time. I welcome all of the delegates who have joined on this platform, and also congratulate Dr. Sachin and Dr. Malvika who will be conducting this session. And thank you so much. Over to you, Sachin.
Thank you, Renu ma'am. Now I call upon Dr. Amol Pawar sir, VP MahaIP. Amol sir is there? Amol sir?
No, sir.
I think. Okay. Uh, now I request Dr. Bela ma'am, scientific convener of MahaIP, to address the gatherings.
Good
Bela ma'am.
evening, everyone. Yeah, good evening, everyone. Thank you for inviting me to speak a few words. First of all, I'm so excited because vaccinology remains one of the most important domains today with ever evolving scenarios. And I have my favorite speakers today. So I'm very excited to hear them all, as well as all the other people who have joined. It is a super successful Maha IP academic event, and I congratulate all the OB, EB scientific workers who've been working behind the scenes very hard. So we can go ahead with the scientific event today. Thank you.
Yeah, thank you, ma'am. Dr. Prashant Jadhav sir is there? I think sir has not joined. Dr. Ramakant sir? Okay. Now for next proceedings, I request Dr. Malvika ma'am. Please go ahead. Dr. Malvika Kulkarni ma'am.
Good evening, all.
Just 1 minute, Malvika ma'am. Ramakant sir is there. Sir is a advisor for today's program. So I request Ramakant Patil sir to address the delegates. Ramakant sir, please.
Thank you, Sachin. And wonderful program and very nice going. I don't want to be a hurdle between the galaxy of speakers. And these are the scholars of Platkill. So we are all the more eager to hear from them. Thank you. Over to you, Sachin.
Yeah, thank you, Ramakant sir. Malvika ma'am, please go ahead.
Good evening, all. Today I have been assigned the duty of introducing all our stalwarts. I would begin with our expert, Dr. Srinivas Kasi sir. He is a consultant pediatrician from Bangalore. He is the past president of IAP Bangalore and also the past vice president of the National Respiratory Chapter of IAP. He has been on the advisory committee of vaccines and immunization practices as a member since in 2011 and 13, as a convener in 2020-2021, and advisor in 2022 to 23. He's the editor of the IAP Question and Answers in Vaccinology and the very trustworthy Purple Book of IAP. He has contributed to many chapters on vaccinology in various IAP textbooks. He has delivered 7 orations and 4 endowment lectures. I request Dr. Kasi sir to say a few words.
Do you really want me to talk? Because I'm going to do a lot of talking later on.
Okay. Sir.
Anyway, I'm very happy that MahaIP has taken up this particular program. And I'm really thrilled with the participants today, all stalwarts. I'm sure we're going to have a great feast. And apart from being an expert, I think this is going to be a learning experience for me as well. Thanks a lot. Thank you.
Great words, sir. Fast. Malvika.
Malvika ma'am.
Yes, sir.
Please go ahead with the other CVs.
Yeah.
Little bit fast.
You
Uh,
need to read everything. Just
Yes,
mention our
I
name.
introduced Dr. Sanjay Marathe, sir. He is from Nagpur, and he has been on various scientific committees of the IAP. He is the director of Marathe Childcare and also uh, Colors Pediatric and NICU Care in Nagpur. He has been the national he has been on the vaccine committee of immunization module 2025. He is also specializing in allergic rhinitis and pediatric HIV. Welcome, sir.
He is a past ACVIP member. That is most important.
Uh, I welcome Dr. Sumita Nayak, madam, from Bangalore. Uh, Madam is an acclaimed academician with various degrees and various PG diplomas in counseling and even medical legal sciences. She has she has been working as a consultant pediatrician in Bangalore, and currently she's the president of IAP Bangalore 2025. She has also been on the South Zone EB member for IAP. She has been the national convener for IAP in various IAP modules, and also has been an active member of various presidential action plans. It's a very elaborate CV, but all I say is that she has been very active in various boards of IAP and also is an expert in vaccinology. She is also awarded Women's Achievers Award by various NGOs in Karnataka in 2025 and 2026. Welcome, ma'am. I welcome Dr. Chetan Trivedi sir from Ahmedabad. He is a senior pediatrician and infectious disease consultant. He was the assistant professor and infectious disease consultant at the UN Mehta Institute of Cardiology and Research Center. He was the honorary secretary of IAP Infectious Disease Chapter and the vice president of Infectious Disease Chapter right now in 2026. He has been the president of IAP Gujarat in 2023. He was the EB board member from Gujarat in 2016 and 2021. He has authored many chapters in the many books of IAP, and he is the convener of and contributor to national and a national trainer in various central IAP modules. Welcome, Dr. Chetan Trivedi, sir.
Thank you.
Next, I welcome our very own Maha-IAP stalwart, Dr. Sagar Kulkarni, sir. He is a pediatrician from Chhatrapati Sambhaji Nagar, and he is the national convener of vaccine module in 2021-23. He is also the faculty in many state conferences of Mahapedicon, Mahaniyocon, Gujarat Pedicons, the national faculty and contributor in vaccinology workshops, and many of the central IP immunology modules. He's the chief editor and contributing author of many vaccinology books, especially the Vaccinology Simplified book. He's the chief editor and contributing author to the Immunization Ready Reckoner 2026. He also is the head and author of vaccinology section of OSCE Masterclass 25-26, the latest by JP publication. Welcome, Dr. Sagar Kulkarni, sir.
Now we are starting a first session. Dr. Sanjay Marathe sir will be speaking on immunization in special situations. Over to you, Marathe sir, please.
Am I audible and my slides are
Yes,
visible
sir.
also?
Yes, sir.
Good evening, everybody, and thank you, MyIP, for the opportunity to speak in this academic platform. The topic given to me is a vast topic. It is very difficult to finish within 15 minutes. Then I thought, let us discuss few things which are important for all of us to know. And if I have left something, then that can be discussed during question and answer session. We have got UIP, we have got NIP, we have got ACVIP schedule, we have got CDC schedule, we have got WHO schedule. But that is for 95% of the people who are usually coming to us who are immunocompetent and will require the same schedule to be followed. But there are 5 to 10% where there is a special situation, and why it matters? Because as we say, the same size of shoe will not fit to everybody. So standard schedules do not fit every child. They might have an increased risk, and the window to protect might be very narrow. There is a problem with the live vaccines, the inactivated vaccines, and for all of us just to know that inactivated vaccines in these special situations are generally safe, but in immunocompromised, the immune responses may not be the same as immunocompetent person. Live vaccines, and many of the times in severe immunocompromised patients, are not indicated and can be given in a specific period, which we are going to see. And as the rule of the immunology says, that do not restart, continue the catch up in a very specific situation. You have to start with the first dose. What are the special situations? Now there are various conditions like the patient who is on HIV positive, who is having a disease, a patient who has received chemotherapy or who is on a chemotherapy or a radiotherapy or some leukemias and lymphomas, chronic conditions like chronic kidney disease or chronic lung disease. They will require a special consideration. A patient of a sickle cell disease going for an splenectomy or congenital spherocytosis person going for a splenectomy, then they will require a special immunization schedule. These patients may have got the altered immune responses, may be more susceptible to the infection, which are otherwise not that serious, will have more mortality. Every time we'll have to assess the risk versus benefit and which vaccine schedule benefits that individual the most. We'll have to select that. A personalized approach. You cannot make a standard guideline to say that you for any immunocompromised individual give this immunization schedule. That is not. Now, what are the general principles of the immunization? As we say, these immunocompromised patients are at greater need for the vaccines, but they will require vaccines in a different format. All inactivated vaccines, I say, they are safe, but their vaccine efficacy and immunogenicity might be less than expected in an immunocompetent person. In severe immunodeficiency, as a rule, all live vaccines are contraindicated. I'm talking about the injectable live vaccines, whereas in mild to moderate, live vaccines may be given. Many of these conditions may require higher doses, or sometimes the boosters are required, which we'll see in some patients like hepatitis B or some additional doses of PCV or quadrivalent meningococcal vaccines, more doses are required. And many of these patients, after vaccinating, will have to demonstrate seroconversion by doing the antibody titers. So that will ensure us that this patient who is immunocompromised, though may not be severe, but he has responded to our vaccination schedule and now he is protected. These patients, many times, even if they have been vaccinated before, may require tetanus, rabies, or varicella immunoglobulins because the previous vaccination may not be considered as adequate to protect them. Some conditions may require additional doses of quadrivalent meningococcal vaccine, polysaccharide pneumococcal vaccine, or HIV vaccine, even if they have crossed that particular age. Most important is the household contact of these immunocompromised individuals. These household contacts must be protected adequately, especially for PCV, MMR, varicella, flu, and hepatitis B vaccine. In this situation, you are basically trying to give a cocooning protection to that immunocompromised individual. Because the OPV is a transmissible disease, you will have to avoid giving OPV to this household contact. Here we'll prefer IPV. Just to put it in and question this, some example, a 28-year-old father is in household contact of 3-month-old infant on chemotherapy, which is the best vaccination guidance for him. Avoid all vaccines to prevent shedding is not a good idea. Only receive inadequate influenza vaccine, definitely not a good option. Or defer all vaccines until the infant finishes chemotherapy, certainly not a very good option because then the patient can get infection through the household contacts. So the best option for us is to receive routine vaccine, including MMR and varicella. Avoid live attenuated influenza vaccine if the person is on a profoundly immunocompromised in a protected environment. Inactivated vaccines like TCV and flu and everything can be given, and these household contacts must be protected. Patient of immunosuppressive drugs, this is a situation where many of the times they are put on methotrexate, azathioprine, or many times on 6-mercaptopurine. This you can keep it in your table, and you can keep these doses. For methotrexate, the dose is per week. For azithromycin and 6-mercaptopurine, the dose is per day. If the patient is receiving less than this dose given, then he is not immunocompromised, and all vaccines can be given as a routine one. Now, of late, many patients are put on biological response modifying drugs, also called as BRMS. They act on various limbs of immune system, and their immunosuppression is variable, not consistent. So, as a rule, suppose somebody is trying to put the patient on BRMS, and you have a window of 4 weeks, all the live vaccines can be given with the gap if you have got 4 weeks period, and all live vaccines can be given, all inactivated vaccines can be given if you have a gap of 2 weeks before starting the BRMS. For example, somebody in irritable bowel syndrome is put on infliximab in 3 weeks. Serology shows non-immune to varicella and MMR. What should be done? As I have discussed, the B option is to be followed. Give MMR and varicella now. Start infliximab more than 4 weeks after live vaccine, so that individual is adequately protected against mumps, measles, rubella, as well as varicella. Rest of the options, I am not going into the details. Now, as a rule, once you have started the BRMS, then till we stop the treatment 3 months from that, you cannot give any live vaccines. And for an exception to this is rituximab, because the peculiarity of this rituximab is that there is a severe immunosuppression. Many times, a patient who has received rituximab is considered as naive for the immune. Whatever he has received before already been suppressed adequately by giving the rituximab, and many times we'll have to start the immunization as if he has not received any vaccine, like what we do it in hematopoietic stem cell transplant. Now, if the mother is taking some BRMS during antenatal period, no live vaccine should be given for at least 1 year from the last one. This we have to keep it in mind. These are the principles. Now, let us go for antibody containing products. Many times we have seen the patient is receiving blood, paxil, plasma, platelet transfusion, immunoglobulins at various doses. We must know when live vaccines can be given. Whenever I say live vaccine, it is related to the injectable live vaccine. A child who has received IVIG 2 grams per kilogram for Kawasaki disease, when can MMR, which is the live vaccine, can be administered? 3 months, 6 months, 8 months, and 11 months. Here the answer is 11 months, because it depends on what the dose of IVIG, which contains antibodies against your live vaccines. Not live vaccines, the organisms like mumps, measles, rubella, and chickenpox. We'll have to give this vaccine only after 11 months. So it is not necessary that you should keep everything, you have to mug it up. Just follow this. Just follow this chart. This is the CDC guidelines. Roughly, I will say, if you are using the washed RBCs, you need not wait even for a day. You can give the vaccine whenever you want. If you are giving the antibody IVIG less than 400, the usual dose you can wait for 3 months. For any whole blood, packed cell, RBCs, and plasma, you have to wait for 6 to 7 months. Suppose you are giving 400 milligram per kilogram of IVIG, you have to wait for 8 months. If you are giving high doses, you are giving many times in ITP, you give 1 gram per kilogram, you have to wait for 10 months, and Kawasaki, you have to wait for 11 months. For antigen-specific immunoglobulins like hepatitis B immunoglobulin, rabies immunoglobulin, or varicella immunoglobulin, the waiting period is 3, 4, 5 months, and that this chart you can keep it in your OPD, and whenever you come across this problem, you can just follow this principle. Now, this is another situation. Varicella zoster immunoglobulin is indicated in the newborn if mother develops herpes zoster 3 days before delivery, primary varicella 10 days before delivery, primary varicella 3 days before delivery, or past history of chickenpox. If you know the principle that as all of us know that you have to remember 5 days before and 2 days after. Why this? Because this is the time where the viruses are multiplying, but there are no antibodies. So mother has not transferred any antibodies to the child, and so child is not protected. And the transplacental transfer of the viruses can lead to a very severe neonatal varicella and very high mortality associated with this. As far as the herpes zoster is concerned, herpes zoster means the mother has already received, the mother had varicella, so good amount of antibodies are already there. She has already transferred to the baby. So if mother gets herpes zoster, whether 5 days before or 3 days after, you need not to give varicella zoster immunoglobulin to this child. I think this is very clear. Now, another question, a little twist in this. A 9-month-old infant received MMR vaccine. Unfortunately, after 5 days, he is put on IVIG for ITP. What is the best next step regarding MMR? No further action required. Repeat MMR after 3 months. Repeat MMR after 8 months. Check measles IgG at 6 weeks. The best option, if you go and follow the chart, it says, if you have given a vaccine and next 2 weeks, this is the time where there is maximum multiplication of the viruses and activation of the immune system. If you give IVIG in this period of 2 weeks, it will suppress the multiplication and the immune response. So this is considered as an invalid dose. And as the waiting period for IVIG 400 milligram is 8 months, you will have to wait and give MMR after 8 months. A child received MMR unknowingly 2 weeks after PRBC. Again, the rule is same. You'll have to wait for 3 to 6 months from transfusion because you have given it within 2 weeks. The principle remains the same. Now, if mother develops localized herpes zoster 2 days after delivery, we have discussed about the chickenpox after 2 days. Here, the varicella zoster, and the preterm baby is 32 weeker. What is the best management? Varicella zoster immunoglobulin mandatory. No varicella zoster immunoglobulin is required. Start IV or cyclovir. Separate mother permanently. Here, as we have already discussed, mother had disease in the past. Therefore, she is getting herpes zoster. She has got good antibody titers. She must have given good antibodies to the child. So, varicella zoster is not required, but ensure that she is covering the lesions adequately if she is feeding the child. Otherwise, the patient can get chickenpox from this herpes zoster. Now, a child who has got acute lymphoblastic leukemia on a maintenance chemotherapy has got category 2 dog bite. He has previously received rabies vaccine. What is the most appropriate management? Defer rabies vaccination until chemotherapy, because we say in chemotherapy you do not give anything. Give rabies vaccine only 2 doses as we give it because he has already received previously post-exposure or a pre-exposure. Give rabies vaccine plus rabies immunoglobulin as per the schedule, 2 minute doses, or give double dose rabies vaccine on each visit. You have to keep in mind, whatever he has received before, if he is on chemotherapy, he is immunocompromised. His previous immunity cannot be a very reliable factor, and you do not know what protection he is still having. So this should be considered as he has not received anything, and we must give, because rabies has got 100% mortality. Therefore, we must give full rabies schedule of 5 doses and immunoglobulins too. So you have to consider whether it is category 2 or category 3, and an immunocompromised host, it is considered as category 3. Now this question, a 10-year-old child previously completed pre-exposure rabies vaccination 7 years ago. Little twist I have given to this. He was on chemotherapy and completed 6 months back. Today sustained a category 2 dog bite. What is the appropriate management? The few things which has come to my mind, he has received chemotherapy, this pre-exposure prophylaxis about 7 years. For next 5 years, he has received chemotherapy, and for last 6 months, he is off the chemotherapy. So, is he an immunocompetent person at present? The answer is yes. He has received pre-exposure rabies, but then we are not sure because how much damage the chemotherapy has done to this child. So, I am not very sure whether he has been protected to some extent, and now he has got category 2. So, should I consider this as an immunocompetent with category 2 bite? So, I personally feel I must give a category 2 immunocompetent, give all full schedule with ARV only, and immunoglobulins are not required in this. But this question can be discussed at the end, and we'll ask Kasi sir what should be our approach, or this is the correct answer. Now, in hereditary spherocytosis, he is scheduled for a splenectomy. She has received only UIP vaccines, and when the PCV was not available. The principle you should keep in mind, this is not an uncommon situation. A patient who is going for splenectomy, is at a higher risk of developing the severe diseases because of the capsulated organisms, and these are typhoid, PCV, hip, and meningococcal. As the age of the child is less than 2 years, and now he is 18 months old, he has not received PCV anything. So, what is the schedule? Now I will give, I think the question should be, the PCV schedule was there. The PCV schedule was already there, so he has received 3 doses before the age of 3 months, before the age of 1 year. Now the immunization recommended before splenectomy for this child, I will have to give 4th dose of PCV, followed by PPSV 23 after 8 weeks. But here the age of the child is 18 months, so I will wait for the age to be above 2 years, and then I will give the PPSV 23 after the age of 2 years, and second dose of PPSV I will give after 5 years of the first dose. I have to give 2 doses of meningococcal, quadrivalent meningococcal vaccine 8 weeks apart. I will have to give additional dose of hip. If the patient has not received, then I can use pentavalent vaccine which has got an hip, but hip is so important because there is 200 times more risk of developing hip infection in this patient. I will also give him 1 dose of TCV and regular dose of influenza because they have got severe influenza disease. When I should give all these things, I should finish everything if it's a planned splenectomy at least 2 weeks before. But unfortunately, patient, I could not give all these vaccine. Then when should I give it? I should give this vaccine after 10 to 14 days. Once patient has recovered after splenectomy, again I will give all these vaccines. In what principles you should keep in mind in chronic renal failure? These patients of chronic renal failure, they respond better to the boosters rather to the primary vaccines. Then their antibody titers as well as cell-mediated immunity is less as compared to an immunocompetent. Their waning is also very fast. They have some issues with the antigens like hepatitis B and PCV. So we'll have to check it every time and we'll have to get additional doses. And these are the few principles. So if this patient is coming to you and is likely to go for chronic kidney disease, you ensure as a pediatrician that every vaccine has been given, and especially for hepatitis B, you have ensured seroconversion at that time. So you'll be very sure that this individual is being protected against hepatitis B because this patient might be required a lot of hemodialysis and all that. So hepatitis B previously vaccinated, then we'll see the serological, and if it is more than 10, we'll not give a booster. But every year, if he's on hemodialysis, we'll measure the anti-HBs level, and anytime if it is going less than 10, I will give 1 booster and continue with this. For PCV, according to the age, suppose he's 10 years old, I will give him 1 PCV, followed by PPSV, followed by PPSV 23 after 8 weeks, and second dose of PPSV 23 after 5 years. Double dose of the hepatitis B is not recommended less than 20 years of age. And regular flu vaccine, even if he's 10 years old, will be given because he is at a risk of developing severe flu infection. This is a very common question, so I thought I will just discuss in a couple of lines, and we frequently come across this issue. Now the principle is any child who is on 2 milligram per kilogram of prednisolone till the age of 10 kg, till the weight of 10 kg, that is 20 milligram per day, and after this 10 kg, anytime if he is on 20 milligram per day for more than 2 weeks, that individual is immunocompromised. So during this time, I cannot give live injectable vaccines. Inactivated vaccines can be given. Especially we come this problem with the MMR, varicella and LAIV. When can I give this vaccine? When you have stopped this dose of 2 milligram per kilogram or 20 milligram per day for at least 4 weeks, then you can give this vaccine, the live injectable vaccine to this child. Rest of the things, if the child is on less than 2 milligram per kilogram, if the child has received 2 milligram per kilogram for less than 2 weeks, if he is on inhaled corticosteroid, he has been asked to apply some steroid preparation, or if he is on an alternate day steroid, these are not the contraindications for giving a live injectable vaccines. So this is the crux of, because this is very commonly discussed. Before I end my talk, these vaccines in pregnancy and lactation, because pregnancy is not an compromised situation. This is basically an immune altered situation. On priority to a pregnant woman, what we should give, that Tdap preferably between 27 to 36 weeks. Influenza can be given at any trimester, but if it is given in the third trimester, the child is also protected for 6 months. COVID is recommended. RSV is now, the vaccine is available, Abrysvo, can be given between 32 to 36 weeks. You have to be very careful about this timing. Then inactivated vaccines can be given if it is required. What is contraindicated? Live MMR is contraindicated, varicella is contraindicated. But unfortunately, the vaccine has been given, which is an attenuated strain. It is not an indication to terminate the pregnancy. This is all in short 15 minutes I can discuss with you all. If there are questions, we can take up now or we can take up at the end. Thank you so much.
Thank you, sir,
Sanjay.
for clearing so many of doubts about special situations in vaccination. I request Dr. Srinivas Kasi sir to give his expert comments.
Yeah, thank you. For 15 minutes, you did a great job, Sanjay. Okay, covered up very well. Most of the very, very crucial and element issues. One, regarding splenectomy, I think we need to emphasize that revaccination is necessary, even if you have been vaccinated in the past. I think that is very necessary. Even if you have received PCV in the past, you require one additional dose of PCV followed by PPSV 20. That is one thing we need to remember. And we got to have some idea about biological because it is being used so commonly now.
Very true.
That some working knowledge should be there. What we must remember is that some biologicals are not involved in any aspect of the immune response. So there no gap is necessary at all. Classical example, if you use antiplatelet, anti-complement eculizumab, or use asthma, lipolimab or omazumab, though the cytokines do not in any way are involved in the immune response. So basically you don't need to give, you can give it in. Maximum gap is for the rituximab because it is an anti-CD20 monoclonal antibody. So it literally destroys all your B cells, memory, everything. Your name, you got to restart vaccination again. I think except for these two issues, if there are any further questions, we can take it at the end. Thank you, Sanjay. Again,
thank you, sir.
Congratulations, a very nice presentation.
Thank you, sir.
Thank you, Srinivas sir. Now I request Dr. Sumita Nayak madam to speak about the latest hot topic of adolescent medicine, the adolescent immunization.
Thank you, ma'am. Let me share my slides, please. Ma'am, hope it is visible.
Yes, ma'am.
Yes.
Good evening, and thank you for this opportunity to talk about the adolescent immunization. What we will be discussing this evening is the need for why do we need to be talking about this particular topic of adolescent immunization. Also discuss a little bit of the adolescent vaccines which are currently available in the schedules, the catch-up vaccinations, the special situation vaccines in adolescents, what are the newer vaccines, and if time permits, a few case scenarios. So with this, let's jump straight in and see why is it important for us to understand that adolescent immunization is essential. So if we look at the population data, this is the data from 2011. Let's look at the pyramid, and it shows that the base of the pyramid, that is from 5 till 19 years of age, that is the largest cohort of the population. So we need to understand that 20 to 25% of our 1.3, 1.4 billion population in India is the adolescents. So this is the latest data which is available now. This is the 2022 population pyramid of India. No change. So we still have around 180 million of our population being the adolescents. So it's absolutely essential for each one of us to ensure that immunization occurs in this vulnerable age. Now, why is it essential? Besides the fact that it is a large cohort, it's most important that we boost the waning immunity. So whatever primary immunization has been done up to the school-going age, we know that there is a fall in the immunity, antibody levels, titers decrease with age, and therefore we definitely need to boost up these. The natural boosting of some diseases does occur, but a lot of times children do not, the adolescents are not exposed to this natural boosting. So therefore, we need to give them doses of immunization. Many times adolescents miss out. So the primary immunization is done up to first year, second year, subsequently the school age immunization also may not be done. The extra vaccines that we give that is recommended from ACVIP may not have been given. Therefore, catch-up immunization has to be done for these adolescents. This will definitely go a long way in controlling disease as well as eliminating disease. And most importantly, there are some specific infections which occur in the adolescent age. So the hot topic of discussion these days is the HPV vaccine, and that is one classic example which is commoner in this adolescent age group. So the infection occurs at that the peak of infection we know is at around the age of 20 to 25, hence ideal to immunize in the adolescent age. Now, are there challenges? We do understand that the rates of adolescent immunization are very much minimal, and we do not really have too much of data. But what are the challenges? Most often it is the missed opportunities. So the adolescent comes into the pediatrician's office when he or she is unwell, and that's the time they just come for treatment, and there is an opportunity which is missed. So it's very important that we take each and every opportunity that comes to us to counsel and to, first of all, to inquire and then to counsel about the requirement of adolescent immunization. The public is not aware. They think vaccines are only for kids. This concept definitely has to be changed. So we have to inform the public that immunization continues right until the age of adolescence. So until 16 years, they must be immunized. There is a growing concern about vaccine safety. There are a lot of misperceptions. There are a lot of anti-vaxxers who come up with half knowledge, and the news spreads very rapidly these days on social media. We need to counter these misperceptions about vaccine safety. The importance of this immunization, definitely we have to talk about, and we have to ensure that the adolescents do come in contact because they hesitate for various reasons. There are challenges which we need to accommodate and ensure that adolescent immunization happens. So if we look at the immunization chart, this is the ACVIP immunization chart. So there are just a few vaccines which are recommended in the adolescent ages. So from 9 to 14, the blue zones are the ones which are recommended. Everything else is the special situation vaccines. So with this basis, let's look at what vaccines are recommended in adolescents. Another word about this Kishore Mitra card, which has been brought out, a very beautiful card from the AHA, IAP AHA, and it's a good idea for us to utilize this for our adolescents. So what are the vaccines which are available, which are currently recommended for adolescents? Well, there are basically only two vaccines which are routinely recommended in adolescent ages. That is the Tdap at 10 to 11 years and another dose at 16 years. The HPV vaccine, which we know recommended between 9 to 14 years as a 2-dose schedule. Above the age of 15 years, it is 3 doses. And in immunocompromised above the age of 9 years, it is a 3-dose schedule. So these are the basically two vaccines which are currently recommended for the adolescent immunization. What about the catch-up vaccines? Well, the whole bunch of catch-up vaccines, as we know, in case it has been missed out in the earlier years, MMR has to be given, varicella, typhoid conjugate, hepatitis B, rubella, and the hepatitis A vaccine. So there are the special situations. Just now we have listened to the talk on the special situations from Dr. Marathe. So the vaccines which are recommended for the special situations to the adolescents, we start with the anti-rabies. So this is the special situation because we do not currently routinely recommend it as a pre-exposure prophylaxis to all children and adolescents. However, these days, a lot of adolescents are out. They are outdoors. They go for trekking. They volunteer with NGOs caring for street animals. There are a lot of pet animals these days at home. So these are the situations wherein we can recommend the pre-exposure of 3 doses, post-exposure of 5 doses. Now, the JE vaccine has to be given only in the endemic areas, again, 2 doses given 4 weeks apart. This is the recommendation for the adolescents as well. Meningitis is given as a single dose. Again, who is to be given? The high-risk groups. And what are the high-risk groups? In cases of meningitis outbreaks, yes, adolescents need to be covered with this vaccine. The immunocompromised, they definitely need, because they are at high risk of meningitis, of infection with the organisms. Those going to the Hajj, yes, they need to be given this. Students traveling overseas for studies, a lot of the overseas universities have a requirement wherein the meningitis vaccine has to be given. And finally, the adolescents who are residing in the endemic zone. So once we have an idea of the geographic areas where meningococcal infections is common, those are the areas where the vaccine has to be given. The PCV20 has currently been licensed above the age of 18 as a single dose, again for the high risk and the immunocompromised. And a very, very latest entrant is the hepatitis E vaccine. So this is given in a 3-dose schedule, again licensed between the age of 18 to 65. So this is again the for the high risk group. We'll discuss in a little while as to which are the groups. Now, what are the newer vaccines? Well, as of now, the newer vaccine which is in the pipeline is the dengue vaccine. So let's look at each of the vaccines now which are recommended for the adolescents. The Tdap vaccine, we know, the ACVIP recommends a dose of Tdap between the ages of 10 to 11 years as an adolescent booster, a repeat dose at 16 years, and subsequently either the TD or the Tdap every 10 years. So it's probably a TD to be given every 10 years after the age of 16 years. That's the recommendation. Now, we need to know what is the schedule for wound management. So I think we'll just spend a little while here trying to understand what has to be done in case of wound management, because there are oftentimes cases who come in repeatedly injured and they go into the ER and they are given a dose of tetanus toxoid. So please remember, if you have this in mind, you will remember how to manage the cases. So if the adolescent has received 3 or more doses, depending on the number of years, you would have to give, you may need to repeat the vaccine per se if it is over 5 years since the last dose, and there is no need for any immunoglobulin. So the only situation where immunoglobulin is to be given is when there are less than 3 doses given and the wounds are not clean. So that is the only situation where tetanus immunoglobulin has to be given, and it's a good idea to keep this chart. So please remember, frequent administration of the tetanus vaccine not really recommended. Moving on to the HPV vaccine, currently we have 3 different brands. I needed to put out the brands because please note the age recommendations are different for each of the vaccines. The Gardasil 4 is licensed for use between the age of 9 to 45 only in females, whereas the Gardasil 9 and the Cervavac are recommended for boys as well, as we have considered it a gender neutral immunization. For Cervavac, males and females between 9 to 26, it's licensed, whereas the Gardasil 9, there's a slight difference. Females 9 to 26 and males only 9 to 14 years. So kindly make your choice of the vaccine based on the current licensing in India. What is the dosage schedule? Again, very important to know. There is a dosage schedule. There's a minimum interval which needs to be maintained from 9 to 14 years, 2 doses given between 0 and 6 months, with a minimum interval of 5 months between them. Above the age of 15 years and in all immunocompromised states, 3 doses need to be given. The minimum interval between the first and second dose, which is given at a 0, 2 and 6 month schedule, is 4 weeks. Between the second and third dose, it is 12 weeks. Most importantly, between the first and the third dose, a minimum of 5 months needs to be maintained. In case any of these minimum intervals are disrupted, well, the dose is considered as invalid and you definitely need to revaccinate. What about catch-up immunization? So routinely, the Cervavac is recommended as a catch-up for females 9 to 26 years. And for females between 27 to 45 years, this is based on shared clinical decision, which doesn't really come in to our discussion on adolescent immunization. But just for completion, we need to understand that only the Gardasil 4 is currently licensed in this age. So we come now to the catch-up immunizations. So what is the catch-up for hepatitis B? So now if an adolescent has never received any prior immunization with hepatitis B, then a 3-dose schedule of 0, 1 and 6 months has to be given. What about the MMR vaccine? To be given to those who have missed or have received incomplete immunization. You definitely need to do it. If they have missed it, then 2 doses to be given as discussed earlier. The rubella vaccine is essential for the unimmunized girls, as we do not have, or we may not always have access to the standalone rubella. The MMR vaccines need to be given. Students traveling overseas, yes, a lot of overseas international universities have a recommendation and a need for MMR, documented MMR, recent MMR immunization. They can be given, and mumps protection is essential for the male adolescent. So considering all these factors, you need to do a 2-dose of MMR vaccine 4 to 8 weeks apart if no prior immunization given. What about the varicella vaccine? Well, above the age of 13 years, you need to do 2 doses at a 4-week interval if they have not received the immunization before and there's no history of chickenpox in the past. Documented history is really important. Below the age of 13, you do 2 doses again at a 12-week interval. So please note the intervals are different, which is age-based. So the reason 2 doses is given is that approximately about 15% of them, 15 to 20%, do not respond to the first dose. Hence, the second dose is given. Also, the older individuals, so older individuals, adolescents, if they have not had chickenpox earlier, have not had varicella vaccine, they are more likely to become seriously ill and have very severe disease complications compared to the younger children. Hence, important to give them. And again, students traveling overseas. So these are the group or the cohort which requires the varicella vaccination. What about the influenza vaccine? This is recommended for the high-risk groups. So what are the high-risk adolescent groups? Those with bronchial asthma, sickle cell disease, immunocompromised states, etc. Those who are in contact with these high-risk or immunocompromising states, they must be given the influenza vaccine. What strain do you use? The latest one available. When do you give it? Ideally, pre-monsoon. So that is how it is recommended in India. What about the hepatitis A? Well, the hepatitis A vaccine, there are 2 types we know, the inactivated and the live attenuated. Both are good, high immunogenicity. Inactivated is 2 doses given 6 to 12 months apart. Advantage of a live attenuated is that a single dose is sufficient. Please remember, in immunocompromised states, you cannot give the live attenuated vaccine. As well as in case of outbreaks, live attenuated vaccine is not to be given. You have to use the inactivated vaccine, 2 doses, 0 and 6 to 12 months apart. Now, what is the cohort to which the hepatitis A vaccine is required? Well, those who are traveling to the areas of high endemicity, males having sex with males, illegal drug users, those with clotting factor defects, and definitely those with liver disease. So this is the cohort to which the hepatitis A vaccine must be given. Moving on to the typhoid conjugate vaccine, a single dose is currently recommended as per ACVIP. So a single dose of the typhoid conjugate vaccine to be administered if not given previously. We have a whole bunch of vaccines, all are good. A couple of them are WHO pre-qualified. End of the day, all are immunogenic, so you can choose whichever you want. Now, the meningococcal vaccines, we have 2 particular brands currently available. Let's look at what the ACVIP recommends. Adolescents 11 to 12 years of age and a booster at 16 years to be given to the high-risk groups. So what are the high-risk groups? We've just had a discussion, asthenia, functional or anatomical, persistent complement deficiency, or those who are taking the drugs which inhibit the complement, those persons living with HIV, during outbreaks of disease, adolescents traveling and staying in regions of high incidence, those going for Hajj, and those living in dormitories. So this is the very high risk group. They must definitely receive a dose at 11 to 12 years and another booster at 16 years. Finally, of course, the students traveling overseas. Now, what about the JE vaccine? Here, we need to know that there's a difference between the National Immunization Program and the ACVIP schedule. While the NIP says that it is given at 9 months along with MR and vitamin A, and the second dose at 16 to 24 months along with the first booster. ACVIP recommends it at 12 months and at 13 months. So 12 months along with the hepatitis A vaccine, 13 months standalone. And the catch-up vaccination as per ACVIP is any time until 18 years. Now this you need to give it in the areas which are endemic for JE vaccine, and trials are available for co-administration. So the JE vaccine can be very safely co-administered with the Hep A, the meningococcal or the rabies vaccine in the endemic areas. Now a word about the rabies vaccine. So we have discussed that it has to be given in the high-risk groups. There are various types of vaccine available. The post-exposure vaccination, we have two schedules, the Thai Red Cross, which is the intradermal, classically given in the government sector, at a two-site. So it is given as a two-site regimen, day 0, 3, 7 and 28, that's 22202. WHO and IAP recommendations for the ID is again 3 doses adequate, whereas the SN protocol is what we generally follow, the intramuscular, wherein 5 doses are recommended for previously unimmunized persons. So this is what is recommended by the NCDC, 5 doses. WHO and IAP recommends a 4-dose schedule. Now, what about the pre-exposure prophylaxis? Now, it has been found there are various studies which show that children below the age of 15 years are responsible for over 40% of the cases of animal bites. Adolescents, as I said earlier, a lot of them are outdoors, they are vulnerable to dog bites, multiple bites, and at various sites of high innovation, that's head and neck areas, etc. So it is recommended as an optional vaccine for all children by AP. NCDC guidelines says, as we have just discussed, the intramuscular route 0.5 or 1 ml per dose based on the preparation, or the intradermal route, which is 0.1 ml. The schedule is day 0, day 7 and day 21 or 28. So it's a 3-dose schedule given as the pre-exposure prophylaxis. What about the Prevnar 20? So now there is the Prevnar 20, which has been licensed for use above the age of 18 years. It has 7 extra serotypes. A single dose is recommended IM, and once you give this Prevnar 20, as we have just discussed, in the immunocompromised cohort, we talked about giving the polysaccharide vaccine, polysaccharide 23 vaccine. Well, if it is above the age of 18 years and it's an immunocompromised condition, a single dose of Prevnar 20 is adequate. So the requirement of the polysaccharide vaccine is practically taken away. So a dose of PCV20 is adequate. Studies have shown that if you look at the extra 7 serotypes, the light green bars are the single dose, the barred ones are the 2 doses of PCV20. So excellent seroprotection after a single dose as well as after 2 doses to the extra serotypes, and to the matching PCV13 serotypes, it is as good. So a single dose of PCV20 gives adequate protection. So this is above the age of 18 years. Now, another newly licensed vaccine is the hepatitis E vaccine, the HEVRI-Vac. This is India's first recombinant vaccine against hepatitis E, and it is indicated for which groups? So active immunization against hepatitis E in adults that is above the age of 18, that's 18 to 65 years in the high-risk populations. What are these? These are those with persons with chronic liver disease, immunocompromised systems, as well as those women in the childbearing age. So these are the recommendations. How is it given? 0.5 ml is the preparation in the deep intramuscular route, and sorry about that. It is administered in a 3-dose schedule. So easy to remember, it's similar to the hepatitis B scheduling, 0, 1 and 6 months. So if you require to give it in the high risk population, hepatitis E vaccine is definitely available. The new and much awaited vaccine is the dengue vaccine. So quick word about dengue. Is there any disease burden studies in India? Yes. The adolescent age, as we note here, the 9 to 17 years, across the country, there is a burden, especially in the southern regions. Almost 70% prevalence has been shown. Therefore, yes, we have 2 vaccines in the pipeline. Hopefully, we will get the licensing across through very shortly. that is the TAC 003, the Q dengue from Takeda, wherein 2 doses need to be given at 3-month interval, already been licensed in some countries across the world. The TV003 or the butantan NIH vaccine, a single dose, again awaiting. This is in the late stages of trials. Serum Institute, Panacea, etc. are working on this. We do hope that it will be with us shortly. Do I have time, ma'am, or do I need to stop? Malvika, ma'am? Dr. Sachin?
Yes, ma'am. You can take
I
three,
have
four
just
minutes.
I just have 3 case scenarios. So very quickly, this is a 12-year-old brought with exposure to chickenpox. There are 5 kids in his class with varicella lesions. Is there any role of post-exposure prophylaxis? So this is something which we need to know as there are outbreaks in school. So of course, we know that varicella vaccine is extremely effective if it's given within 72 hours of exposure. However, if they come even up to 5 days after exposure, it does have a role to play, the vaccination, because it has a protective efficacy of almost 62% against any type of disease. Most importantly, almost 80% protection against moderate to severe disease. So it's a good idea if they come in even up to 5 days after exposure, please go ahead and immunize them because there is a role of post-exposure prophylaxis. I have 2 case scenarios referring to the HPV vaccine. Herein, there's a 10-year-old girl who has taken the first dose of HPV vaccine, and then she's gone away and come back after when she's age of 15 years. So now the dilemma is how many more doses, because we know that above 15 years you need to give 3 doses, below that it's 2 doses. However, since the first dose is given below the age of 14 years, you just need to complete it as a 2-dose schedule and just give another single dose and complete her schedule. So there is no need to restart or to give any more doses apart from 1 more dose. Now, another scenario which comes to us is that the child has already received her 2 doses of HPV4. He's 13 years old, and at 10 years of age, she has received her 2 doses. Now, the parents have heard about the HPV9 vaccine, and they want to know about the additional protection against the 5 serotypes. So, what will we know? Now, what will we do, and how are we going to counsel the parents? So, as per currently available data, the 4 serotypes give protection against 83% of CA cervix, the serotypes causing or responsible for CA cervix. There have been no trials now on the further catch up after HPV4 to give the HPV9, no data on any trials. So there is currently definitely no guidelines on giving the as a catch up or to cover the extra 5 serotypes in HPV9. So you do not have any guidelines. If the parents insist, you need to give the age appropriate number of doses of HPV9 and complete the immunization. So with this, I finish my presentation. Thank you very much for the opportunity given and for your patient hearing.
Thank you, Sumita ma'am, for this elaborate talk, which was very crisp, yet it was explaining all the intricate details of adolescent vaccination. And it also gave us valuable information about the latest vaccines like hepatitis E and Prevenar 20. I'm sure there are many questions which we will be taking later. I request Dr. Kasi sir to give his expert comments.
Thank you. Very exhaustive, very complete presentation by Dr. Sumita. I think HPV dosage in adolescents is a very, very hot topic. We should have a separate session to discuss that. I don't think we should even attempt to discuss it now because it's going to take a lot of time. The other issue is, which also was there in the chat box, was one, if you remember 2 years back, ACVIP recommended that we should give 1 dose of a tetanus or containing vaccine again between 16 and 18 years. Now, this recommendation was based on the fact that in many surveys, sero surveys of population, protective levels of diphtheria and tetanus antibodies were very low in the population, in the adolescent population. Moreover, this 17 to 18 years is the last point of contact with the pediatric age group. Please remember, preventive medicine literally stops at 18 years. Very rarely do pediatric physicians follow preventive medicine. So probably an additional dose at this age to boost the immunity, so it will last for at least another 10 years. And even if you see, the incidence of diphtheria is quite high in the adolescent age group, though it should be a childhood disease in most of the developing countries. Should it be Tdap? Should it be TD? It can be either, but there is no additional benefit of giving a pertussis because the duration of protection of pertussis becomes less and less with every subsequent dose after the first 5 doses. Maybe just a year or two at the most. So it does not justify the extra cost. That is the reason why the recommendation was done regarding Tdap and TD. Now, one thing which I think any adolescent talk should cover is the question of assent and consent. Say if a 1 year or 2 year or 5-year-old child is brought to you, no one asks the child, do you want to take the vaccine? Are you agreeable? You pin down the child and you give the vaccine. But this is unacceptable for an adolescent girl. It's literally a violation of her body if you try to forcibly vaccinate her. So here comes the question of assent. Assent does not have any legal validity in our country, but it has a lot of ethical justification. You have to talk to the girl, you have to get her assent, say, I am ready to take the vaccine. If she's ready and not adamant, I think one should not attempt to give the vaccine forcibly. You have to postpone it, sit down, talk to her and postpone it. Now, talking about assent, many countries in the West, many Western countries have made assent legally valid. For example, in UK, anyone above the age of 16 can give consent for HPV vaccination, and that figure is 12 years in USA. There is something called the Gillick principle. It's a set of questions which determines whether a young adolescent is capable of taking decisions. And in fact, if a child satisfies the Gillick principles, even as young as 10 years can give assent for vaccination. So I think assent is something that is very necessary for every adolescent vaccination. And I think rest all were covered very well. Thank you, Dr. Sumita. Thanks.
Thank you, sir.
sir. Thank you, sir.
Now I request Dr. Chetan Trivedi, sir, to start his talk on cold chain in my practice and safe injection practices.
Good evening, friends. At the outset, I would be thankful to MahaAP for this wonderful opportunity to share my views on given topic. Now, as we know that this is a huge topic, I don't know how will I finish it in the given time, but still I'll try to do it. But most important point, what I want to highlight is the topic given to me is a cold chain in my practice and safe injection practice. So I will be sticking to my topic. So now the first question is, what is cold chain? We know that cold chain is a system of transporting and storing vaccines within the recommended temperature range from place of manufacture to point of administration. So it's a huge sort of thing, and it involves not only the equipment, trained staff, but also the monitoring. Now, what is the importance of maintaining cold chain? See, vaccines are the temperature sensitive biological products which are made up of maybe carbohydrate, lipids, protein, nucleic acids, which may become less effective or even destroyed if when it has been exposed to temperature outside the recommended range. So that's why it is very important to maintain this cold chain. Now, what has been mentioned is outside recommended range. So cold chain, that doesn't mean just the heat only. So this is the 2 to 8 degree plus 2 to, that is a recommended age for all the freezer, whatever refrigerator put vaccines. And if you go above it or below it, both are going to damage. So heat or cold may damage. So, but the difference between heat and cold damage is, cold is, whatever damage occurs, it is immediate loss of potency following freezing. So there is only one way go. While heat is, it is a cumulative loss of potency that is not reversible, of course, but it is not that one-time exposure of heat and the vaccine has been destroyed. While cold, it is one-time exposure and it is gone. Now, that's why we should be knowing which are the heat-sensitive and freeze-sensitive vaccines. So heat sensitive, we know that OPV, measles, MR, MMR, rotavirus, and BCG. So those are heat sensitive, will be having stringent requirement of keeping in a cold chain. That is the upper part of the compartment in domestic respirator we'll be discussing. Freeze sensitive, these vaccines should not be frozen, because suppose TT containing vaccine, DPT, Penta, Hexa, TD, TT, they get, once they have been frozen, there is adjuvant damage. Hepatitis B, there is loss of antigen potency. IPV, there is protein denaturation, and PCV, there is adjuvant disruption. So ultimately, these vaccines, this group of the vaccines, they have been freeze sensitive. They should not come in contact with the eyes at all, because otherwise it will damage the vaccine. So now what else can damage the vaccines other than heat and cold exposure? Of course, a strong light, sunlight, ultraviolet and fluorescent. So that's why these particular vaccine, group of vaccine, BCG, MMR, varicella, DTAP, HPV and Rota should not be exposed to light. And that's why majority of these vaccines, they are coming in a amber colored bottle. Now, how do I know that my vaccine has been damaged because of freezing? So there is a shake test. We should be knowing that, suppose if I have an ampule, which vaccine vial, which I am suspecting that is been exposed to freezing or frozen, I will take a similar vaccine with the same batch, and first I'll make it frozen, and after that I'll thaw it. Then I'll keep shake both the vaccine vials and put it by the side to each other, and then I'll wait for 5 to 15 minutes, and I'll see what happens to that particular shaken vaccine. If the suspect vaccine, they are sedimenting slower than the frozen vaccine, then it can be used. But if it is at the same rate of the sedimentation with the frozen vaccine or faster than that, that means you should not use that vaccine that has been gone. So that is one way we have to check for the freezing damage. Now, how do I know vaccine damage because of heat? We know that there is a simple and quick answer, which is vaccine vial monitor. Now, what is it? It is a label which is containing the heat sensitive material, which is placed on the vaccine vial or on the top of the cap, which registers the cumulative heat exposure over time. Now we know there are different types of VVM, VVM 2, 7, 14, 30. What these different days show? They show that it is time in days that it takes for the inner square. We know that there is inner square and outer circular area. So inner square to reach to color indicating discard point if the vial is exposed to constant temperature of 37 degree. That means if it is VVM2, if it is being exposed to temperature at 37 degree for 48 hours, then it will be the VVM will change, not just of 2 days of whatever exposure of temperature. So that's why it is important to see this particular VVM. Now VVM, we should be knowing how to read it. There is a one circle when there is a square in it. If the color in the square is lighter than the surrounding circle, then it can be used. Once it is at the same color or it is darker than that, that is called discard point. We should discard that particular vaccine. It is damaged because of heat. Now, the question to me is how many of my vaccine which I am getting supply in private practice is having a vaccine vial monitor? Hardly any, except for polio. We don't get any vaccine which is having a VVM. Then what should I do? That's why we should be very strictly following this cold chain flow. Now, you know that in NIFP and WHO, there is a huge sort of things manufactured to national store, to state store, district store, PSC and child. But for me, what is important? For me, it's important stock is, because I know the stock is. I have to see that how he stocks the vaccines, because from there it comes to me, my clinic, and I have storage equipments. And during this transportation, also we should be looking at it, how they are maintaining the cold chain. So first, your stockage should be such that it's having a proper facility to store the vaccine in proper condition. Transportation should be proper under cold chain. And then once it is in my clinic, it's my responsibility to maintain the cold chain till I give the vaccine to the child, that is point of administration. Now, you know that cold chain, that there are different components. One is equipment. Of course, there is a storage device and temperature monitoring tools. Personal, that me and my staff, and procedure. We should have a storage protocols that we should be following. So these all three components combine to ensure the proper vaccine transport, storage, and handling. Now, cold chain in my office practice, I will be looking at two things. One is storage device and temperature monitoring tool. Now, when you talk about vaccine storage equipments, what is the choice in our practice? First, it depends where you practice. If you have like a city like me, we hardly have any power supply which is interrupted, or I have an inverter or generator in my hospital, I can definitely vouch for purpose-built refrigerator. But if I am practicing at a place where there are frequent power failure and I don't have the backup of inverter, then I would like to have Iceland refrigerator because it is having a cold over time. We will be talking about that. Suppose if I don't have this option, then can the domestic refrigerator be used? Yes, it is an inferior choice. Of course, it is a compromised choice, but still you can use it with the if you follow certain principles. We'll be discussing it. And must one more important vaccine carrier or isothermal box with ice packs to be kept in your hospital because you in case of power failure sometimes you may require that. So we should be knowing that the ice packs which have been it is ice once it has been perspiring, and if it is shaking it is giving noise, then it is ready to use. You can't use ice pack from the refrigerator compartment immediately and you can use it. Okay, so you need to have a conditioned ice pack. So we should have vaccine carrier or isothermal box in our hospital in emergency situation like prolonged power failure. Okay, now what is purpose-built refrigerator? This is a nice thing to have in our hospital because it is transparent. I think you must have seen the refrigerator in the ice cream parlor, but it is not the same. But definitely it is having advantage that there is no need to modify the vaccine storage because it's uniform temperature 2 to 8 degree all across. Second thing is cabinet temperature is not affected by ambient temperature and is stable and uniform. Evaporator that operates between 2 to 8 degrees. So it prevents from freezing damage. That is also important. Again, defrost cycle that doesn't allow the rise in cabinet temperature. Even distribution of temperature because there is a air circulation. And also there is a good temperature recovery because when fridge is open, there's an air curtain which prevents the outside air to go inside. And most importantly, there is a reading, external temperature reading display with minimum and maximum temperature. That's why purpose-built temperature is good to have. Now, what are the disadvantages of that? Is this the advantage of that? Most important, it doesn't have any holdover time. That means if there is a power failure, it is not sure how many hours you can keep the vaccines into the purpose-built refrigerator because it doesn't have the place to put the water and increase the cold mass. And there is no place to store OPV more than 1 month because that we have to keep in a freezer compartment and that is not part of this particular refrigerator. Now, let us come to understand that what is holdover time. Now, it is the time taken by equipment to raise the inside cabinet temperature from its cutoff temperature to maximum temperature limit of its recommended age. That means, suppose if I have a recommended range is 2 to 8. My refrigerator was showing 3 degree when there was power failure. So it was cutoff temperature. How much time it will take from 3 to reach to 8? That is my holdover time. It depends on ambient temperature, frequency of opening of lid and door, equipment, whether it is empty or loaded, and condition of ice pack lining. So that is holdover time. And you know that different particular equipments are having different holdover time. That is what we have been displaying. So now let us try to talk about the domestic refrigerator. We know that it has been designed and built to store the fresh or frozen food and drinks, not for the special temperature need of vaccines. So there is no accurate temperature control system. So it should not be used. But suppose if you don't have any alternative to store the vaccine, then we have to think how best to be used and what to be selected. One most important thing, it has to be double door, refrigerator and refrigerator compartment separate, frost free as far as possible. We should be exclusively using the refrigerator for vaccines only. No water bottles, no ice cream, no nothing, no milk, nothing. Door still should be good. Vaccine storage plan and chart should be there on a door. So before opening, we should be knowing which compartment, which vaccine is there. So immediately after opening, you can take it. So less time of opening the door. Temperature monitoring tool, because that is not available. Yes, now latest refrigerator may have external temperature that we can be used. And it should be collected by UPS, uninterrupted power supply and voltage stabilizer. So this is what we have to do at least to use the refrigerator. Now, what is temperature monitoring tools? Usually, if you have purpose-built refrigerator or ILR, it comes up with built-in temperature monitoring. But if you want to use in domestic refrigerator, there is minimum maximum thermometer. We have to use the probe or cable inside in between the vaccine you have to put, and that will give you reading. At the same time, when we talk about the freezing damage, that is not possible to understand unless we keep this electronic freeze indicator. There are two types of it. One is freeze tag. So here what happens when this particular tag has been put into the refrigerator and temperature goes less than minus 0.5 for more than 60 minutes, there will be a change in signal from OK display to alarm. Similarly, this freeze watch, it is something like with this bulb with some fluid into it, which is a colorful liquid. If it has been exposed to say minus temperature for more than 60 minutes, it will rupture and it will give color to that particular background paper. So that will give us indication that this particular refrigerator has gone to minus temperature for more than at least 60 minutes. So that is what we can use in temperature monitoring tool as a temperature monitoring tool. Now, when you have to store the vaccines, we should be knowing, as we discussed, certain vaccines are heat sensitive. So those who are heat sensitive to be kept, in particular, when you are putting in refrigerator, we know that cooling is occurring from the above down. So first, initial top shelf and middle shelf, you should be keeping those heat sensitive vaccines. Those who are less heat sensitive, we can keep it in lower shelf. Most important thing is never put anything other than ice packs into the freezer compartment. Don't put anything in the door or that chiller tray or the vegetable tray. We can put in the door and the vegetable tray the fluid or liquid which is non-drinking water to increase the cool mass. Similarly, when you are using ILR top leading, you know that the cooling occurs from below up. So here all the storage requirement will be reverse. So OPV, measles, BCG will be at the bottom and rest will be up. So that is what is required for when you are using a domestic refrigerator or ILR, not for purpose-built refrigerator. Now, what do I do when there is a power failure and I'm using a domestic refrigerator for vaccine storage? We should be knowing that if it is less than 4 hours, then I think we should keep the refrigerator door closed. Till 4 hours, it can manage the temperature. But if it is more, then we should be keeping our backup option ready and we should shift the vaccines. We should have a backup generator or inverter if possible when you're using a domestic refrigerator. Now, I got a new refrigerator or I have changed the refrigerator. Can I use it in next day? No. First needed to stabilize the temperature of new refrigerator before using it. So what we'll do, we start it, put it between 2 to 5 degree temperature maintenance, and then we check the temperature twice a day for 7 days. Once it is consecutive for 2 days, twice a day, the temperature is within recommended range, we can start using this new refrigerator. Now, when you talk about the equipments, now vaccine handling personnel, it includes us. There has to be one vaccine coordinator in our hospital, which should be taking care of everything, all protocols, storage protocols, and they should be knowing what to do in particular power failure. And there will be second staff who should be knowing also if the person is not there. And we should be having regular training of that all staff members because that particular cold chain maintenance is very much important in our practice. So what is the audit list, audit checklist? We should have a dedicated vaccine refrigerator or a purpose-built refrigerator or ILR. You should be having twice daily temperature recording and should be having a chart of it. Stock rotation. We should be having a first in, first out, right? So like what happens, whatever vaccine it is being near expiry should be outside so we can use it, or those with vaccine which have been come fresh, we can put it outside and other older vaccine can be kept in front. Uninterrupted power supply, emergency power backup, and staff training are most important audit checklist. Now, this is second part of my the talk. It is safe injection practice. Now, safe injection practice, what is it? According to WHO, it is a safe injection is that doesn't harm the recipient. One. Second thing, it doesn't expose the provider to any avoidable risk. Three, it does not result in waste that is dangerous for our community. So this is in general safe injection practice. Now, why we are talking much about it? Because there are risks of unsafe injection practice. What are the risks? 30% of hepatitis B chances of getting transmission, 3% of hepatitis C, and 0.3% of HIV. It is usually estimated risk of getting these infection from contaminated syringe and needles. And that's why safe injection practice is important. Now, when I have to convert it in safe injection practice in what as far as the immunization is concerned, before that, at one point, everybody will think that there is always the unsafe injection practice when we are talking about NIP or government setup. But there is this interesting study which was done in Gujarat then when there was 2009 outbreak of viral hepatitis B. What they tried to investigate what happened to them, and they found that hepatitis B outbreak in the state of Gujarat in 2009, 40% of positive cases had a history of receiving injection in the last 6 months from private practitioners. So it is not that unsafe practice is uncommon in our practice in private sector. So that's why we should be knowing about safe injection practice. Now, when we talk about vaccination, I have just divided all the three parts. First, we'll be taking about safety of recipient. How can you do that? Of course, handling and storage of vaccine in cold chain we discussed. We should be taking care of not to have the damage to vaccine. We should ask for the proper history before vaccination so that we should not miss any contraindication, precautions, or some allergy or anaphylaxis like chances. At the same time, we may do error in gene vaccination if we are not asked the history. We should avoid error in selection of vaccines, diluents, syringe needle, and route and site of vaccination. Because these errors ultimately will be unsafe to the recipients. We should be knowing which vaccine to be given, which diluents, whether properly stored or not. Syringe and needle, it should be auto-disable syringe, preferably. If you use disposable, it should be only to prepare the vaccine. Route and site, we should be knowing IM vaccine, which should be given, subcutaneous particularly given. So these all to be kept in mind to avoid the errors. Injection site preparations. Now, do we need to do alcohol swab? Not necessarily. If it is the no, skin is not very clean or dirty, you can use a wet swab. But if you are using alcohol swab, allow it to dry, air dry. Okay, don't blow by the mouth to make it dry. So, and to avoid injury during administration. We know that when we are giving vaccination, a positioning and holding of the child is very important. So you have to make arrangement for that, and then you give vaccination. And most importantly, after vaccination, ask them to wait for 15 to 20 minutes for the adverse reaction monitoring. At the same time, you should be having emergency tray and anaphylaxis tray ready. Now let us talk about safety of ourselves, provider. We need to avoid injuries, that a particular needle stick injury, while preparing and administering the vaccine. You know that maximum injury occurs because of the recapping of needle. So never recap the needle. Now, my question, just put in the chat box the answer. When will you use gloves while vaccinating? Of course, you can put the answers in that. We'll discuss later on. Gloves, so hand hygiene. You should wash your hand with soap and water if it is not clean, and you can use in between. You can use a sanitizer for the vaccination. You not to use gloves all the time. As far as possible, use pre-filled syringes, auto-disable, and pop-up ampoules, because many of the vaccines dilutes are having that pop-up ampoules, as well as they need to be opened by the files. So pop-up ampoules are better, otherwise you may injure yourself. So that's the important thing. And pre-filled syringes, because otherwise while preparing also you may get damage, injury to yourself. Proper position and holding, as because while giving vaccination also sometimes you may injure yourself, so that is important. Lastly, safety of environment and community, because we should have a proper biomedical waste, and we should be, one most important point, we should be of course knowing which are the color codes, which particular things should go in which particular color code bags, but we should keep puncture proof, leak proof, sharp containers for the sharp waste disposal, which ideally should be placed within arm's reach. Means once we are giving vaccination, immediately after that, sharp needles and everything should go in that white container, and that container should not be open. It should be locked and sent directly for the biomedical waste. Why it is important? Because we have seen one of the pediatrician who is giving vaccine by dancing and singing song. He gives the vaccine and he throws the vaccine just like that in the other this thing. That is not acceptable. It is definitely breach of biomedical waste. So we should be taking care of that particular thing. So concluding, cold chain plus safe injection makes effective immunization. Thank you all.
Thank you, Chetan sir, for such a elaborative session. Really, it will be helpful for our day-to-day OPD practice. Now I request Dr. Kasi sir, do you want to comment anything?
Yeah, good presentation. I think every presentation on cold chain should emphasize the fact that domestic refrigerators should not be used for vaccine storage. ILRs and purpose-built refrigerators are more expensive, but cost should not be a deterrent, because today, for the average pediatrician, he generates, I would say, a minimum of 50% of his income comes from vaccines. So we should have the best possible storage facilities. If you make a choice between the ILR and the purpose-built refrigerator, there's a little tilt in favor of the ILR, because your purpose-built refrigerator does not have a holdover time. So unless you have an assured 24 hours power supply, I think a purpose-built refrigerator would not be ideal to store vaccines. One more disadvantage is that purpose-built refrigerators are more susceptible to external environmental temperature than the ILRs. And generally in places where the external temperature goes beyond 40 degrees, some more temperature maintenance by the purpose-built refrigerators are not so good. This is a theoretical point. Maybe it was more common with the older ones, but whether the newer models have eliminated this, I don't know. Chetan very clearly emphasize the importance of not just the equipment, but the procedures and protocols. And the fact is, there should be someone qualified to carry out those protocols. And if that person is not there, there should be another person who can do the job. So you should have someone, your cold chain manager, whoever it is, plus a backup. And remember, prominently put up the phone numbers of all your maintenance personnel, because anyone can call him up and contact him and ask him to do the repair. So that should be very freely accessible. One thing which is very essential is monitoring of the temperature. See, you have, classy refrigerators with built-in temperature monitors, your ILR, but that gives you at that instant point of time. It does not give you a continuous monitoring, which is necessary. So either you should have continuous monitoring, or you should make it judiciously plot the temperature twice a day, 10 a.m. and 4 p.m. Digital data loggers are the best. They are not very expensive, and the good ones cost around 12 to 15,000. You can just keep it in your fridge, the app on your phone, and once a month you can just see the entire log of the temperature measurements, and if necessary you can even download it in case it's necessary for your medical legal purposes. So digital data logger. So I think these are a few points which I just wanted to comment about in the cold chain. All in all, he dealt with it very well. Thank you.
Thank you, sir. Thank you, sir. Now the last talk is on maternal vaccines for infant safety, and talk will be delivered by Dr. Sagar Kulkarni, sir. Over to you, Sagar, sir.
Thank you so much. The topic which has been given to me is maternal vaccination for infant safety. Are my slides visible?
Yes, sir.
Okay. Now we know are vulnerable to many infections immediately after birth, especially during the early few months of life. But we cannot give vaccines to them so soon. Otherwise, we would have loved to give vaccines immediately after birth, like birth dose, but that is not possible. So there are multiple reasons: immune immaturity, very less seroconversion, very low GMT titers, even the possibility of adverse events, reactogenicity, and so on. So what we do, we give the vaccines to the mother who we know that is not the primary beneficiary at that particular time. For example, if I want protection against RSV, I will give RSV vaccine to the mother knowing the fact that she is not the primary beneficiary, with the hope that antibodies will be formed in the mother, and then they will be transferred via transplacental transfer to the baby, and then the baby is going to be protected. Most of this transplacental transfer occurs in the second and third trimester, specifically more in the third trimester. So that's the basic mechanism which we are using this maternal vaccination. Another point to understand is that we want to boost the immunity of not only the mother, but the expectant mothers also, what we call as women of conceiving age, because we want that high levels of specific antibody should be there for her self protection also, and also for transfer to the baby. One thing, we know that if an infection occurs during pregnancy, it can be harmful to the fetus, especially during the period of implantation, organogenesis, growth, and in outcomes like preterm deliveries and functional development. So we want to protect the mother and indirectly protect the fetus also. Now, two things come in our mind. The first is, are we giving a vaccine to an immunosuppressed person? And the second, will the vaccine itself cause harm to the fetus? Now, we know that pregnancy is not an immune suppressed situation, it is an immune altered situation. Yes, we accept a little bit decrease in functionality of CD4, CD8 T cells is there, but the innate immunity, the monocytes, the phagocytes, the dendritic cells, they all take over, and overall, the mother is not highly susceptible to infection. So it is an immune altered situation, and we can give all the vaccines. Point number two is, can we give all the vaccines to the mother? Then there is something called as theoretical risk in pregnancy. Understand that pregnant women are not a part of trials. So most of the trials are done on animals like monkeys and chimps. Then the data is accumulated, extrapolated, and applied to human. So if we find some safety signal, that is called theoretical risk to the pregnancy, and therefore most of the vaccines are therefore avoided in pregnancy from the theoretical risk. As a general rule, all vaccines are generally avoided in the first trimester, that is the period of organogenesis, except TD vaccine and flu vaccine. All vaccines for the benefit of mother or infant are offered in the second trimester. All live vaccines, as I've already said, possess a theoretical rather than a documented risk and are therefore avoided. Inactivated vaccines, they are fairly safe in pregnancy and can be given if indicated. Now, one point I would like to emphasize here, if there is a grave risk to the mother's life, the risk to mother's life is very high. Every vaccine, and when I mean every vaccine live inactivated can be offered to the mother. That we have to remember. So we are talking about two things now: benefit to the mother, benefit to the baby. When I'm talking about infant safety, do not restrict the vision only to Tdap in pregnancy and neonatal pertussis. It is a very broad term. So if I want my infant to be safe, let us say against congenital rubella syndrome, I need to understand I have to give rubella vaccine to the expectant mother or the adolescent age so that she will be immune and my infant will be protected against congenital rubella syndrome. If I don't want my infant to suffer from varicella, I have to ensure that the expectant mother or the woman of conceiving age should have received a varicella vaccine, and so on. So maternal immunization for infant safety, it is divided again into three parts. One is vaccination prior to pregnancy, one is during pregnancy, and one is after delivery also. Now, this part, the vaccination prior to pregnancy, is little bit neglected part because the woman outgrows the pediatric and adolescent age, so pediatricians are not looking towards it. Even the gynecologists also don't look at this particular phase of the life. But it is very, very important as we have already discussed. Which vaccines are important? MMR, varicella, hepatitis B, hepatitis A, hepatitis E, which we just discussed, Tdap, and so on. So yes, we have to see to that the mother is immune to all this infection so that the baby and the newborn baby is going to be protected. Understand one thing, there is always a fear in the healthcare workers' mind that if I give a vaccine to a woman of conceiving age and if she's pregnant, then what will happen? No need to worry. No vaccine given inadvertently during pregnancy is an indication for termination of pregnancy. So don't worry about that thing. Three main parts which we are going to discuss is vaccination during pregnancy, the RSV abrasive vaccine, the Tdap vaccine, and the influenza vaccine. And one more point which we have emphasized is vaccination in postpartum period. Understand, all vaccines can be safely given in postpartum period immediately after delivery, even before the discharge. Now, why this is important? Let us say if we have forgotten to give Tdap in pregnancy, we can offer it after delivery also. Now, how much it will be helpful, that we will discuss later on. But if we keep the mother, the siblings, the father, the grandmother, grandfathers protected, then indirectly the newborn baby is also protected. Coming to the three main parts, let us go to the first, RSV vaccine in pregnancy. Now, we know this is the abrasive vaccine for Pfizer company. It is not available in India, but of course, it is an important one to discuss. Now, this vaccine is given to pregnant women to prevent RSV lower respiratory tract disease in infants from birth to 6 months. We give it preferably between 32 to 36 weeks. It is used in elderly also, but this vaccine is not used in pediatric patients because we know the chances of enhanced respiratory disease ERD in pediatric population. What is this vaccine? It is a pre-fusion F3 protein-based recombinant vaccine. It contains both RSV and B types. Only a single intramuscular 0.5 ml dose is given. It is a lyophilized vaccine and it reduces the risk of severe LRTD by approximately 81.8% in the less than 90 days age group infants, and it reduces the risk of severe LRTD by 69.4% in less than 180 days age group. Now, why this 32 to 36 week gestation? Now, there were studies which were done in which one cohort was from 28 weeks gestation to 36, another cohort was from 32 to 36. We are not going to go into the discharge. The summary is the result was quite well when the age 32 to 36 weeks gestation period was used. The results were better if that was used. In the post-marketing study, let us say when this vaccine was started in Argentina, when the gestation of 36 weeks was chosen, then the effectiveness against hospitalization was noted to be 71.3%. But in UK, when the recommended was from 28 weeks and onwards, the RSV associated hospitalization, the effectiveness was only 57.7%. So understanding the studies also and the post-marketing studies also, we can say that the best period to give this vaccine is between 32 to 36 weeks of gestation. Now, there was a small numerical imbalance in preterm birth. There was a small numerical imbalance in neonatal jaundice, but it was not that much statistically significant. Some numerical imbalance in hypertensive disorders of pregnancy was noted. So this vaccine is not given where preterm birth is contemplated or when we are expecting complications in pregnancy or in preeclampsia. This vaccine is not given in the pregnant lady. Understand at least a minimum gap of 1 month should be there after giving the vaccine. Then and then only antibodies are going to be formed and they are going to be transferred to the baby. Now, if the gap between giving the vaccine and the delivery is less than 14 days, then this infant to maternal antibody ratio is going to fall. In that case, you might have to give nirsevimab monoclonal antibodies to baby also. Tdap and Abrysvo, we are giving the same period. So can we give them both on the same day? Now, concomitant administration has not been studied robustly, so at present there is no such recommendation. Number two, we know that Tdap is given during every pregnancy. So we don't care about earlier vaccination status or what is the immune status. During every pregnancy, we offer a Tdap. Can we do the same thing about Abrysvo? The answer is no. At present, it is done only single time. So what we do next time? So next time you will have to offer the nirsevimab monoclonal antibody to the baby. So can I use Abrysvo in pregnancy plus nirsevimab if both are available? No. In a single setting, you will have to choose either Abrysvo or either nirsevimab monoclonal antibody. So if either has to be chosen, then definitely based on the study, nirsevimab to the newborn baby is definitely the preferred thing. Is there any situation that in spite of giving Abrysvo to mother, I might have to give nirsevimab to the baby also? So there are some such situations like placental insufficiency or prematurity, just like I discussed, delivery occurred within 14 days of giving the vaccine, or if the baby had undergone a ECMO or cardiac bypass or exchange transfusion, in such cases only, I might have to offer monoclonal antibody also to the baby, in spite of the fact that I had given Abrysvo vaccine to the mother. Okay, so coming to the next part, Tdap vaccine in pregnancy. Now, we know that the pertussis disease is highest in the period between birth and 6 to 8 weeks of age. 76% of pertussis related deaths occur in under the age of 2 months only. But again, as we have already said, this is a non-vaccinating age group. I cannot give the pertussis vaccine in this age group. So how to go ahead? We have seen the mechanism. Give Tdap vaccine to the mother with the hope that the antibodies will be transferred to the baby and the baby is going to be protected against neonatal pertussis. Which is the best period? The best period is up to 31 weeks, but it is a very short period. So the next best period, that 27 to 36 weeks period, is taken for giving this vaccine. Is this vaccine really impactful? Now, there was this study about effectiveness of maternal Tdap vaccination in preventing infant pertussis. So, if this vaccine is given in the third trimester, as you can see from the chart, the effectiveness of 77.7% was noted. But see the same chart, if it is given after pregnancy, the effectiveness was only 4.9%. So, that is why giving Tdap during pregnancy in this particular time frame only is very, very important. What about effectiveness of maternal Tdap against pertussis hospitalization? If the vaccine is given in the third trimester, the effectiveness is around 90.5%. It is very good. Safety data, vaccine is safe in pregnant woman. Vaccine is also safe to the fetus also. There is no issue about that. So IAP is safe, foxy, the same vaccine should be considered between 27 to 36 weeks gestation. But we know the government rules. Government wants to give 2 doses. So we are not interfering with the first dose. The TD vaccine has to be given as early as possible when the mother approaches for the first time to the healthcare worker. So we don't change that. But the second dose of Tdap, preferably what we are saying, please give Tdap vaccine instead of TD, and that too between 27 to 36 weeks gestation. Will the vaccine be beneficial to mother? Definitely. If the mother is exposed to a case of pertussis outbreak, also this vaccine is going to be helpful. Number two, Tdap also contains the T vaccine. We know that is important for preventing maternal tetanus and also protecting the neonate from neonatal tetanus. So that also comes under infant safety also. So that is also helpful. And the D part, it will definitely help in boosting of immunity against diphtheria. Coming to the last part, influenza vaccine in pregnancy. Now, we know that influenza results in high morbidity and high mortality in pregnancy. Number one, we know the influenza infection can cause adverse birth outcomes like fetal loss, preterm birth, low birth weight, and even SGA babies also. And the third part, influenza vaccine even protects young newborn babies also. So this vaccine, in fact, helps in three ways. Which vaccine, trivalent or quadrivalent? You can use any. In the inactivated or live, we have to give the inactivated injected influenza vaccine. Which trimester? So influenza vaccine can be offered in any trimester, no issue about that, but still we are going to prefer it in the second trimester as we have already discussed. This vaccination is particularly important in pandemics, epidemics in high circulation period, and definitely we offer it before the high circulation period starts. That is what is very important. As I said, will this vaccine give some protection to the baby? Now, there were multiple studies like Mali study, Nepal study, Bangladesh trial, South Africa trial. The efficacy was good in the initial 2 to 4 months in the range of 60 to 70%, but then it dropped down and in 5 to 6 months, then it decreased. Overall, for 6 months, if we see, as far as Mali study is concerned, the efficacy noted was 37.3%. In Nepal study, it was 30% efficacy only. So yes, it gives a modest protection in a few months, but it drops down by 6 months of age. Remember, healthy infants, healthy children are going to give rise to a healthy India. Thank you.
Thank you,
I think I
Sagar sir.
finished in 14 minutes.
Yeah,
Sharp.
say 1 minute also. Now I request Dr. Kasi sir.
Thank you, Sagar. Very typical of Sagar's presentation, concise and very, very complete. Dr. Sagar, you didn't discuss the possibility of blunting of the immune response in neonates following maternal Tdap vaccination. Can you just few words about it?
Right. So the initial studies which were done were about from DTaP vaccines, and what they noted that there was some blunting as far as the pertussis vaccination response was concerned. As far as other T and other parts of the pentavalent or hexavalent vaccine was concerned, no such significant blunting was seen. But as I said, those countries which had implemented this maternal Tdap vaccination, they had noted that there was no increased incidence of disease in those countries. So the observational studies were quite reassuring, saying that it is not going to cause significant blunting. Though studies showed that some blunting might be there, might not be significant. This blunting is definitely not going to be there after completing the primary series, and definitely not going to be there after giving the booster doses. That is for sure, in short.
Right. I think that's great. Incidentally, the first vaccine to be used in pregnancy was TT, tetanus. And believe me, the safety of tetanus was established by mothers who accidentally received tetanus during pregnancy. And when they went back and looked at the data, they found that it was safe. You see, it was never a randomized control trial with including pregnant women. Now, even if you look at the COVID vaccine, it was not studied in pregnancy. But because there was a high risk to the mother and it's an inactivated vaccine, it was assumed that it will be safe and those vaccines. I mean, no one is going to test vaccines in. Now, the second thing you must remember is that maternal immunization with RSV, classically WHO, the CDC recommend between 32 and 36 weeks. But UK says 28 weeks onwards, because when they examined the adverse effect of between 28 to 32 weeks, the major adverse effects was a little higher incidence of preterm births and pregnancy-induced hypertension. But what must be remembered is all these studies were done during the COVID time, and there was no way to show whether it was the effect of COVID subclinical infections or was it due to the vaccine. Subsequently, now in UK, with extensive usage since 28 weeks of age, there has been no increased adverse maternal or fetal outcomes. So probably 28 weeks also safe. Probably 28 weeks makes more sense because your transmission, I mean, your transfer of the antibodies begins from about 28 weeks, and you are sure that you are going to have adequate levels in the infant's blood if you give it around 28 weeks, because if for preterms, that is extremely important. I think those are just a couple of points that I have to make. I mean, all in all, it was a great
Yeah,
session. As I said, a
as
good value
Kasi sir had
session.
said, especially this was very much noted during when the RSV GSK vaccine was
Yeah.
given in the
Yes.
pregnancy. At that
Yes.
same time, Delta wave variant was also circulating, and
Yes.
that's why they stopped the study. So now
Correct.
we don't have RSV vaccine studies also, mRESVIA studies also. What is remaining only is Abrysvi vaccine, which has robust studies, so that is only used nowadays.
Yeah, and the second thing
And
is
that is,
RSV
they only,
has a very strong adjuvant, and the safety of those adjuvants in pregnancy has not been established.
I think in that study they have noticed two important things: higher incidence of prematurity and higher incidence
Yes.
of mortality also, which was
Right.
0.4 against 0.6%. And
Correct.
that was the reason they do not want to take any risk.
Right.
one
Thank
of the
you.
thing I
One
asked
thing,
in my
one question I
session,
would like to ask, which Marathe sir was discussing about that rabies case, quite interesting case.
That was the
Vaccine was
started
given
on the
before
11th.
chemotherapy.
That was that case has put it at 7:30 in the evening. I thought this should be discussed.
So, final
And
answer
then
from Kashi. If you ask my opinion, memory cells are going to be intact if you give the vaccine prior to chemotherapy. Now, if you give the vaccine during chemotherapy, I might say that yes, you'll have to repeat the whole series. But before
see,
chemotherapy,
Sagar,
I think the memory cells are intact.
if you see the advice given after a chemotherapy or a radiotherapy, that all the vaccine you should give a booster of whatever you have given. Now, rabies being an 100% mortality disease, can you take a chance of just by giving two doses, 0 and 3, and saying that okay, you have received a pre-exposure? Thank you very much. At
No, no,
least
no.
I will
So,
not do
Kashi,
it.
sir,
I
what
will.
is your opinion?
Then I understand following standard chemotherapy, there is definite suppression of the B cells and the memory B cells. So there is a recommendation for giving a booster of all the age appropriate vaccines. I mean, that's a standard practice. Now, as far as rabies is concerned, can we apply these principles to rabies, which has a 100% fatal disease? I think
So we'll have to give complete
wouldn't
dose.
like to take
ARV
a
schedule.
chance.
ARV schedule.
Definitely treat it as a
That is
Benefit of
what
preventive
I
doubt.
thought.
measure. Yes.
So, sir, question to Kasi sir. So suppose the mother who has delivered a baby and had received two doses, two PRBCs because of some bleeding and all that. Now the gynecologist wants to give chickenpox vaccine. Should we use the same principle of waiting 3 to 6 months, or can be given immediately?
These are googly. Now, I think you have to examine the science behind it. Now, mother has had chickenpox. Mother had chickenpox,
No, no chickenpox in the past. Now, after the delivery, they would like to give chickenpox vaccine because she never had
and the mother
chickenpox
had
in the past.
received two. Now, here it depends upon, see, the maternal antibodies through the transfused RBCs generally start falling after about 2 weeks after the transfusion, and it's almost not present by the end of 3 weeks. Of this, how much is transferred to the infant?
No, no, sir. There is no question of being a transfer to the infant. Mother who has delivered a baby now,
Huh.
and she received two PRBC transfusions because of the bleeding in mother, postpartum bleeding
Okay.
or something.
Huh.
Now the gynecologist would like to give vaccine at the time of discharge to mother, either MMR or chickenpox, because mother did not
No,
have
no,
this.
no. I think here there is no urgency for the vaccine. One should follow the principles and wait for at least about 6 months.
Sir, why I'm asking you, the purple book, which is the recent edition, says irrespective of whatever mother has received, you have to give immediately at the time of discharge. So I would like to know
I
what
have
is the
not.
meaning of this
No, no.
on the special situation. It is in 457.
No, no, no. Now I mean, if the mother gets exposed, has not had chickenpox and gets exposed, maybe there's an urgency. There you may take a chance, but otherwise one will definitely wait for 6 to 7 months to give a live vaccine after a packed red blood cells, especially if it was intact plaque blood cells that is not washed or anything.
Yeah. So, sir, but this is given in our purple book. So I wanted just to know what is the exact meaning of this.
I have really not seen this.
Chetan sir want
I
to say something, I
yeah
think.
yeah
Chetan sir.
yeah. I asked in my presentation, where will you use gloves while
Ah, yes,
vaccinating?
yes.
Yeah.
I
Many
had
of people have answered that if you are having some injury over
Network.
any other indication. So here I wanted to highlight the importance of using gloves. Pardon? Hello.
I think
Sir,
it's
network issues there from your side, sir.
yes.
Please off your videos. That will be
Sir,
better.
Ashish sir, can I ask a question? Dr. Surendra speaking.
Yeah, please.
Yes, welcome, sir.
Yeah. Nowadays,
Okay.
in
Am I
the
audible now? Am I audible
yes,
now?
sir.
Yeah. Chetan,
Yes,
yes.
sir. Yes, sir.
So
Chetan,
there
sir, go
was a
ahead.
question. So the answer is when you are giving a, yeah, infiltration of rabies monoclonal antibody or immunoglobulin, you should wear the gloves. Gloves. That is
Only
one of the
indication, sir.
important. Yes,
Yeah.
only one. And then if you have something with lesions over the hands.
Yeah.
So
Well
basically,
taken.
two indications. One is when you're having an injury and you do not want to transmit to the recipient of the vaccine, or recipient has some problem and that should not spread to the giver, one who is administering. Two situations. That's it. No routine use.
Yes.
Surendranath, sir, want
Yes,
to have some
yes, sir.
questions. Yes, sir. Go ahead.
Congratulations. It was an excellent presentation from all the four. Kashi sir, nowadays gynecologists are writing HPV vaccine for the postpartum mothers.
Yes.
They are writing in the discharge card also. But those who have not received HPV vaccine, they are writing them, asking them to take the HPV vaccine.
Yes.
So, technically speaking, normally even splenectomy, we are giving the vaccine after 2 weeks of surgery, taking into consideration that immunological imbalance post-operative.
Yes.
So, which is the ideal time to give HPV vaccine after 2 weeks, or can we give immediately?
Now, see, one is there is no standard recommendation for postpartum immunizations anywhere. We are following it in our country mainly to increase the uptake. Now, we know that pregnancy is a state of relative immune alteration. As Sagar said, there's no immune competence, but there's some immune alterations which happen. Now, these generally take at least 24 to 48 hours after delivery for them to go back to normal. Okay, so technically speaking, anything given after 48 hours should work well. So one need not wait for 2 weeks like after splenectomy or major surgeries.
For cesareans
Kashi sir,
also, sir?
Kashi sir,
Yes.
Okay.
I mean, there's no
Okay.
different recommendation
Kashi
for.
sir.
Yes.
At the outset, I must thank you and all the four speakers. All of them were spot on, and your summing up was really excellent. Just one question, just one request from my side. As I was having a meeting with the district collector today regarding the rolling out the HPV vaccine in the government setup, and there will not be issues regarding the acceptance of the vaccine. The Honorable Collector has requested me to give some audio video messages from the IAP, and
Right.
I cannot ask a better person than you to please draft the basic content of that message to be percolated in the target population by virtue of the direct meeting with the schools or through the by using the NGOs like Rotary, Lions and all. Otherwise, the acceptance in government also will be a big challenge to the government. So, my humble request to Kasi sir and all the four masters just to draft a message or a video message in Vernex, of course, so that we can give a good message to the community because there are a lot of anti HPV vaccine uh, messages are percolating in the various social media. So that's a big challenge also, another challenge.
Okay, I think good idea. We can do it, all of us together.
Chalo. Almost
Sure.
it's 10:58. Any questions? Anyone?
अरे
We should
झोपू द्या
finish.
आता सचिन लोकांना.
Yes, yes. Yes.
Thank you, sir. Thank you all.
That's
Thank you.
it.
Thank you.
Thank you
Just
all. Thank
you.
you.
no,
Thank
sir. No,
you.
sir.
Thank you,
Thank
Sir,
Thank
everybody.
just
you.
1
Thank you
minute.
so
Yes.
much
Yeah.
for
Yeah. No,
joining.
I think there is some more formality. Yes.
Yes, sir. uh, now it's time to vote of thanks. So I extend my heartfelt thanks to all esteemed speakers, especially respected Dr. Kasi sir, for sharing their valuable knowledge and practical insights with us. And many thanks to Dr. Sanjay Marathe sir, Dr. Nayak ma'am, Dr. Chetan Trivedi sir, and Dr. Sakar Kulkarni sir. Your sessions truly enrich us. My sincere thanks to all participants who joined us today and made this session interactive. First, and now I want to thank respected President MahaIP, Dr. Joshi sir, Secretary Dr. Renu ma'am, all OBs and EBs of MahaIP as well as Central IP for the constant supports. So this program really marks a strong academic journey of Maharashtra IIP 2026. And we look forward to so many much more enriching sessions ahead. So good night all. You can now sign off. Now I officially declare it's the end of